Good evening, everyone. I hope I'm audible. Dr. Miyanga, please confirm that you can hear me.
Yes, you are very audible.
Yes, thank you very much. Welcome, everyone, to today's episode of the Neurotorium Educational Series, looking at schizophrenia for this week, and this is the second day of this episode. Yesterday, Dr. Miyanga introduced us to this topic, first by taking us back in time through the evolution of the understanding of this condition and through important figures that have contributed to the understanding of the symptomatology as well as I hope now I'm better, I'm clear, Dr.
You are very clear.
All right. So Dr. Miyanga took us back in history in time and talked about prominent figures like Emil Kraepelin, Bleuler, and their contribution towards the understanding of this condition called schizophrenia. And then they took us all the way to the current understanding where we look at the DSM-5, the ICD-11, and how they define this condition, schizophrenia. So he defined schizophrenia for us based on the symptoms in the DSM-5, where he talked about the delusions and he described the delusions based on what people might say, but also gave what the actual delusions should be. Then hallucinations, disorganized speech, disorganized behavior, and then the negative symptoms, which might be like covert of speech, isolation, and others. He also went ahead and compared for us the DSM-5 and the ICD-11, and then gave a full description of how this condition actually impairs functioning and put a great emphasis on this point of impairment in functioning. So today, Dr. Miyanga is back in the hot seat, and this time round he has come to dissipate heat towards us by taking us through the understanding of what happens in the brain. Today he's going to dissect the brain for us, take us to the cellular level, particularly at the synapse, and tell us what happens at the synapse, making some individuals get schizophrenia while others do not. And he will give us insights probably of why certain use of substances or other conditions might present in a picture like schizophrenia that can confuse others, whilst other things cannot. For example, when you look at certain substances that people use, they might present with the psychosis that we defined yesterday, while other substances do not. And this comes from either the different receptors or the particular neurotransmitter systems that they affect. So allow me invite Dr. Miyanga to take us away on today's episode. Dr. Miyanga, you're welcome.
All right. Thank you very much. Dr. Katame, am I audible? Kindly confirm and I proceed.
Yes, please. You are very audible.
Yes. Good evening, ladies and gentlemen. We thank you so much for sparing time to be with us. My name is Miyanga Mark, and I'm a psychiatrist, and I'll be taking us today through the neurobiology and etiology of schizophrenia. But thank you so much, Dr. Katama, for giving that reminder of what we actually discussed yesterday. So every thought, emotion, and hallucination always begins at this point. That is at the synapse. An impulse reaches the axon terminal, and then calcium ions rush in. And what we are seeing here are vesicles containing neurotransmitters. With the influx of calcium, they go and fuse with this presynaptic membrane and eventually end up releasing their components, or rather what they contain, which is the neurotransmitters, which then go into the synapse and across to interact with various receptors. So at the receptor point, they may either trigger a new signal or they may even end up silencing one. And after doing what they're supposed to do, within milliseconds, These neurotransmitters are supposed to be cleared away, either by getting reabsorbed into the presynaptic membrane and eventually the axon, or they may be broken down by enzymes found within, or they may even be taken in by glial cells. At the end of the day, if this rhythm of releasing and them interacting with the receptor and getting uptaken somehow breaks, the information flow is going to falter and reality is going to start distorting. So it is important for us to acknowledge that our brains communicate through neurotransmitters, each of them binding to specific receptors, much like the way a key fits a lock. And these systems together actually shape how we think, how we feel, and how we behave. For example, dopamine that we are seeing here acts through several receptor subtypes, that is D1 to D5. And through that, it is able to control motivation, reward, movement, and a number of other domains. Serotonin here acts through what we call the 5-HT family of receptors and is able to regulate mood, sleep, anxiety, but it doesn't end there. It actually also interacts very closely with dopamine. Glutamate that we are seeing here is actually the main excitatory neurotransmitter within our CNS. And it uses mainly three types of receptors. That is the NMDA, AMPA, and kinase receptors. The opposite or the antagonist of glutamate, for lack of a better word, is GABA, because GABA is the main inhibitory neurotransmitter in the CNS. And so it helps to keep the excitation in check. Noradrenaline that we are seeing here is responsible for tuning attention and then for arousal. Acetylcholine, on the other hand, helps to fine-tune memory, and it plays a very big role actually in learning and memory. And lastly, histamine also plays a role in alertness. And certainly if you have ever prescribed any antipsychotic, it also plays a big role in side effects of some of the antipsychotics that we enjoy prescribing for people. So I'm inviting you to picture the brain like a car with two pedals. It has a go pedal or acceleration pedal, and it has a stop pedal. So the go pedal within the brain in this case would be glutamate, that it drives, it stimulates brain activity. And the stop pedal is GABA because it is inhibitory. So it keeps things in check. At the end of the day, a healthy brain balances the two for someone to have smooth thoughts, smooth movements, and normal emotions. Glutamate that we are talking about here connects a number of key brain regions. You can think of the cortex, to the thalamus, to the hippocampus, and more, and ends up forming communication highways that make thinking coherent. I earlier noted that it works through three main receptors. So the NMDA receptor is mainly for learning and memory. The AMPA receptor is for fast signaling, and the kinase is for fine-tuning. I am not going to go so much into the biochemistry of these receptors because that is a whole different field and war. But we shall see later what happens when NMDA receptors underperform within the context of schizophrenia. As I earlier noted, GABA is actually the brain's brake. It is the main inhibitory force, and it acts through three main receptors, GABA A and C, which open chloride channels to calm neurofiring, and GABA B, which works through G proteins for slower and steady control. So If glutamate drives the brain forward, I would like you to take it that GABA applies the brakes to the forward motion. And so when these GABAergic brakes weaken, as some studies have shown in the context of schizophrenia, suddenly you start having thoughts racing, you start having associations loosening, and the person becomes overwhelmed with sensory input to the cortex. So schizophrenia is not just the fault of one neurotransmitter, but it is a problem of a deeper imbalance and a breakdown in coordination between excitation and inhibition. The norepinephrine that I talked about earlier is the chemical that keeps the brain alert and responsive, and it is produced in the locus coeruleus, very tiny area of the brain, right here, but very important. Because from here, it is able to send signals all over the brain, to the prefrontal cortex for attention and planning, to the limbic system for emotional regulation, to the cerebellum and spinal cord, for coordination and blood pressure control. So I would like you to think of adrenaline as the brain's inbuilt alarm system. When something important happens, think of a sudden sound, pain, a threat, the locus coeruleus goes into action. It releases norepinephrine, or what some of you prefer to call noradrenaline, and in the process, it sharpens our focus and prepares us in various ways to act. However, what is important within the context of schizophrenia is that this system as well becomes unstable. So under stress or exhaustion, excess noradrenaline floods the system and disturbs emotional control and attention. And this actually is why psychotic episodes often follow periods of intense tension or sleeplessness. But in the same process, when you're tensed up, you're not sleeping well, sleep hormones are actually being produced and they tend to amplify the effects of noradrenaline and even disrupt dopamine balance. Now let us come to the king himself, that is dopamine. Dopamine is one of the brain's key messengers. It fuels a number of things. Talk of motivation, talk of movement, talk of reward. Dr. Mugume the other day was talking about substance use disorders, and dopamine was huge in that. But it is involved in a number of other disorders. So dopamine is produced from a molecule called L-dopa, and it is broken down after use by enzymes such as monoamine oxidase and catechol or methyl transferase. Now, I would like you to think of the brain as having four main dopamine highways. And we are going to start with the first highway. That is the mesolimbic pathway, which I am touching right now. So the mesolimbic pathway starts in an area called the ventrotegmental area, and it projects to other limbic regions such as the nucleus accumbens, called the pleasure center, the amygdala, the hippocampus. And this pathway mediates motivation, reward, and emotion. But in the context of schizophrenia, overactivity in this pathway is strongly linked to positive symptoms. We shall get to know what positive symptoms are and how they come about. Then next, let us talk about the mesocortical pathway. The mesocortical pathway also arises from the ventral tegmental area. But as you hear the word cortical, it projects to the prefrontal cortex. So the prefrontal cortex is the region which is responsible for planning, judgment, social reasoning, and all other forms of executive functioning. When the mesocortical pathway is underactive, it actually contributes to the negative symptoms of schizophrenia. We also have two remaining pathways, which we know play a very big role, especially in relation to the side effect profiles of some of the drugs, such as CPZ, which we like giving to our patients for us to have a moment of peace. So the nigrostriatal pathway, which is here, it originates from the substantia nigra pars compacta, and this tract travels to the dorsal striatum. It is primarily responsible for motor control. That is what we should know. So in the event that you have given someone 400 milligrams of chlorpromazine and maybe added some other drugs, which we may not talk about now, there will be dopamine blockade, not only in the mesolimbic area, not only in the mesocortical area, but also in the nigrostriatal pathway, which is actually responsible for coordination of motor movement. And therefore, do not be surprised if you give someone CPZ and they end up with what we call extrapyramidal symptoms, such as tremors, rigidity, bradykinesia, all symptoms that mimic Parkinsonism. However, when you give someone this drug, it is not just going to affect the nigrostriatal. It is also going to go ahead and still block dopamine receptors within the tuberoinfundibular pathway. So this pathway connects the arcuate nucleus of the hypothalamus to the pituitary gland. Dopamine is at times referred to as the prolactin inhibiting hormone. So it inhibits release of prolactin. But when you give your antipsychotics and these receptors are blocked, it means that prolactin levels are going to rise. And this will lead to a number of effects such as galactoria. A man or a male patient comes to you with, when he's almost developing breasts, there are menstrual irregularities within women. There is decreased libido and a number of other effects that come about as a result of increase of prolactin. So in short, schizophrenia is not caused by too much or too little dopamine everywhere, but rather it is about regional imbalance, overactivity within limbic circuits and underactivity within mesocortical circuits. So this imbalance explains both the symptom diversity and the treatment challenges which we are going to talk about. So normally, dopamine here helps us assign that is within the mesolimbic pathway, okay? That is the pathway from the VTA to the nucleus accumbens and other limbic structures. Dopamine here mainly helps us to assign importance to experiences, such as recognizing a friend's voice or sensing something that matters for you to pay attention to it. But when dopamine increases within the mesolimbic pathway, the brain actually starts tagging random things as being deeply meaningful. You may be walking on the road and just a casual glance from a stranger will make this person think that this person or the stranger is deeply in love with you. Or a casual glance at times may be interpreted the other way. Probably this stranger, the way he has looked at me, it seems he plans to kill me or to harm me somehow. So in essence, the mesolimbic system, because of an overload of dopamine, becomes overactive. It floods perception with false signals of significance. So by reducing dopamine activity in the mesolimbic pathway using antipsychotics, we actually help to restore a balance and ease those positive symptoms. Talking about the mesocortical pathway, we are talking about negative symptoms. So negative and cognitive symptoms come from too little dopamine this time within the mesocortical pathway. This mesocortical pathway connects the midbrain to the prefrontal cortex, which I said earlier is the center for judgment, planning, emotion, and other executive functions. So when dopamine is low here, motivation, pleasure and mental clarity actually end up fading. And clinically, we end up seeing a person with alogia and hedonia has lost interest in things they used to enjoy. Avolition has no will to engage in any form of activity. A flat affect, there is diminished emotional expression on the face. So, while the mesolimbic system overfires, I would like us to remember that the mesocortical system instead in schizophrenia tends to slow down. So the treatment, the tricky part is the treatment must handle the overactivity of the mesolimbic, but at the same time, support the mesocortical for it to become more active. So that takes us to what they call the conundrum of treating schizophrenia. It is important to note that in a healthy brain, dopamine levels across different pathways are usually balanced. It is not too high, it is not too low. Here you can see that the mesolimbic pathway, dopamine levels are at just the right level to maintain, motivation, emotional regulation, and so on. And the person has no hallucinations or delusions. At the same time, the mesocortical pathway on my right is also stable. So it is allowing for clear thinking, planning, and emotional expression. And so you will not have negative symptoms. This is a system that is in harmony in a normal person. And dopamine is doing its job in both pathways. Now, in schizophrenia, you can guess that the balance totally shifts. On one side, the mesolimbic pathway is in overdrive and you are having positive symptoms. But on the other side, the mesocortical pathway has very low dopamine levels and therefore is working very slowly and the person is having negative and cognitive symptoms. So we are currently dealing with two opposite problems happening at the same time. Too much activity in one circuit here and very little activity in another circuit. And that is the central dilemma actually in the treatment of psychotic illnesses generally. If we use CPZ, for example, to lower dopamine enough to control hallucinations this side, the same CPZ is going to come to the mesocortical pathway and block B2 receptors, and we are going to end up with most likely negative symptoms or cognitive dullness. However, if you also decide to start here and say, these negative symptoms are treating my patient badly, why don't I give something to boost dopamine? They will be resolved here, but the mesolimbic pathway will again be in overdrive because of you boosting dopamine. So this brings us to talk about our drugs. Typical of first generation antipsychotics work by blocking D2 receptors, mainly in the mesolimbic pathway. But the problem is that they don't block selectively. They act on D2 receptors throughout the brain, including areas where dopamine is already low, such as the mesocortical pathway. So in the mesocortical pathway, this is definitely going to worsen negative and cognitive symptoms. In the nigrostriatal pathway, where is it? Yes, it is definitely going to disturb motor control and you end up with extrapyramidal side effects. In the tuberoinfundibular pathway, the same blockade is going to cause prolactin levels to shoot up. You end up with breast enlargement and menstrual changes. Atypical or second generation antipsychotics, this is where they come in. They are more selective, partly blocking dopamine, but also acting on serotonin receptors. There are 5-HT2 receptors within the mesocortical pathway, which if activated, can actually help to increase dopamine concentrations within that pathway. So instead of a full block, some of them actually act as partial agonists, stabilizing dopamine in the mesolimbic pathway, but also helping to keep it up slightly high in the mesocortical pathway. And therefore, you end up with less extrapyramidal side effects when you are using second generation or atypical antipsychotics. We have talked a lot about dopamine. So the question remains, what exactly triggers this imbalance? What makes the dopamine to shoot up or to shoot down in the mesocortical pathway? And now, ladies and gentlemen, this is where the glutamate hypothesis provides an answer. Under normal conditions, NMDA receptors on GABAergic interneurons, which we know are inhibitory, are active. NMDA receptors are stimulatory. Now, stimulation of an inhibitory neuron actually leads to increased inhibition. And so if these NMDA receptors are working on GABAergic interneurons, there will be increased inhibition. On the glutaminergic projections, we are aware that glutaminergic projections are stimulating in nature. But if there is an inhibition on stimulation, it means you have less stimulation. So when there is this inhibition, we end up with less glutamate being released. And certainly you'll agree with me that if there is less glutamate interacting with dopaminergic neurons, then there will be decreased release of dopamine. That is how usually the normal brain is supposed to work. But within the context of schizophrenia, unfortunately, it has been found that NMDA receptors tend to underperform. So those GABA inhibitory neurons lose their braking power. They cannot properly suppress the excitatory glutamate neurons anymore, which end up releasing increased glutamate. And certainly increased glutamate is going to stimulate dopaminergic neurons more, and we are going to have a release of more dopamine than the brain is supposed to have. And there we have our positive and negative symptoms of schizophrenia. So as we continue, I believe someone may ask me about treatment-resistant schizophrenia. Some people with schizophrenia have been found not to respond to standard dopamine blocking medication. This could be thought of as treatment-resistant schizophrenia. I'll be saying TRS. So TRS is defined as little or no improvement despite taking at least 2 antipsychotics from 2 different classes. This should have been at an adequate dose and duration. The duration given in NICE guidelines is you've used this medicine the right way, you had tapered to the highest possible dose for 6 to 8 months. So emerging research suggests that TRS may not just be merely a severe form of schizophrenia, but it is actually a biologically distinct subtype of schizophrenia. So scientists are suggesting that we don't only have one route to schizophrenia, but we have a number of mechanisms by which schizophrenia can come about. And some of those mechanisms actually may lie in glutamate signaling or network dysfunction rather than the excess of dopamine alone. So in essence, treatment-resistant schizophrenia reminds us that schizophrenia is not a single disorder. It is actually a spectrum with multiple biological pathways, but which lead to similar symptoms that we evidence in schizophrenia. We are going to quickly go through the hypotheses underlying the causes of schizophrenia. First is the neurodevelopmental model of schizophrenia. Do not be intimidated by this long word. So today, schizophrenia is increasingly being viewed as a neurodevelopmental disorder. And I talked about it yesterday, actually, that you inherit genes from people you even didn't discuss with, okay? But along the way, you have a number of other challenges that pile on top of this genetic weakness, and you end up getting the illness. So during normal brain development, neurons multiply. They migrate to their proper positions within the brain. And following that, they start to form circuits. But later, as we are growing up, these circuits need to get refined. So circuits in the brain are refined through what we call synaptic pruning, but together with myelination. These two processes of refining circuits, which I've talked about, continue well into early adulthood. Now, in people who go on to develop schizophrenia, this fine-tuning or synaptic pruning and myelination seems to go off track. So there is excessive pruning of excitatory connections, and then sadly there is also reduced growth of inhibitory ones, especially in the prefrontal cortex. So glutaminergic activity or excitatory activity is going to have a pattern in your brain, for lack of a better word. And this partly explains why actually psychosis often emerges in late adolescence or early adulthood, that is between 18 to 25 years. That is the very period when the brain's wiring is still maturing. Synaptic pruning is taking place and myelination is taking place. Unfortunately, it's going the wrong way. Then the social developmental cognitive model of schizophrenia brings together everything we discussed right from yesterday. That is the biology, development, and life experience. And it suggests that schizophrenia doesn't arise from one single cause. No, but rather it arises from an interaction between genetic vulnerability, neurodevelopmental changes, and social adversity. So when a person grows up under chronic stress or trauma, say you experience childhood abuse, repeated rejection, these experiences can shape biased cognitive schemas. The person may start to actually interpret neutral or innocent or ambiguous events as threatening or personally directed. At the same time, early neurodevelopmental changes and dopamine dysregulation also make the brain's stress response circuits to become more reactive. So for a person with these abnormal neurodevelopmental changes, when stress or adversity occurs later in life, the brain actually tends to over-interpret it through the distorted lens that someone has grown with. And this may lead to paranoia and delusional beliefs. So essentially, stress, biology, and cognition interact in a loop. In recent years, evidence has showed that schizophrenia is not just about neurotransmitters, but it seems to also involve the immune system. So some studies using positron emission tomography imaging have demonstrated increased activity of microglia, which we know are the brain's resident immune cells, which are particular, and this increase of microglial activity has been found most prominently in the frontal and temporal lobes of people with schizophrenia. The microglia, which are hyperactive within these people, end up releasing cytokines, which have been found to be able to actually alter synaptic function. Alter synaptic function and contribute to neuroinflammation. The interesting thing, though, colleagues, is that even individuals who have a very high risk of psychosis, for example, your mother and father both have a history of psychosis. Studies that have been carried out among these people have also shown that these people have a higher than normal activity of microglia within the frontal and temporal lobes. So beyond dopamine and glutamate that I have been harping on about, schizophrenia may also actually be a disorder of immune dysregulation. But we have not ended on immunology alone. Now psychiatry is looking beyond the brain and looking at the gut. You know, the trillions of bacteria that live in the gut are collectively known as the microbiome, gut microbiome. And they play a role in regulating immunity and how neurotransmitters are formed and broken down. And I love the fact that Dr. Katama, in his description of the gut-brain axis when he was presenting depression, he actually explained this well. So research has actually showed that people with schizophrenia have a different gut bacterial profile, especially in pathways that are linked to glutamate and vitamin B12 metabolism. We are drawing towards the close of my presentation. It is important to acknowledge that genetics may load the gun, but ultimately, the loss of your job, getting beaten by your wife or by your husband, getting chucked, and the various environmental challenges that we face as we journey through life are the ones that pull the trigger. Urban upbringing and chronic psychosocial stress also play significant roles, and they likely amplify stress hormones and inflammatory responses that affect neuronal development. I would like to emphasize that none of the factors I have talked about alone can cause schizophrenia. But together, if you have the genetic predisposition and the environmental factors come in, you may end up developing schizophrenia. During the COVID-19 2021 lockdown, a lot of people were using what they like to call akachai. That is tea, but tea that is made of cannabis and water. And they said that it would help to resolve COVID, or it had protective values. Now, ladies and gentlemen, research shows that using cannabis, especially from a young age in high amounts, can actually increase the risk of developing psychosis or schizophrenia. And the risk is actually much higher for people who already have a genetic or family vulnerability. Cannabis, yes, doesn't directly cause schizophrenia, but it can trigger or bring forward the symptoms in those who are predisposed. So if you had genes for developing schizophrenia, and maybe God had planned that probably you'll develop schizophrenia at the age of 25. When you take this kachai with cannabis, the 25 may be brought forward to around 20 or even earlier. So in simple terms, for some people, cannabis can act like a spark in the brain that is already wired for risk. Schizophrenia doesn't trace back to a single faulty gene. That is very important to note. But rather it is a story that is written across an entire genome. So a massive global study was carried out, and it looked at DNA from more than 35,000 people. And it found that 108 genetic regions were actually linked to the risk of developing schizophrenia. And most of these regions had never been seen before. Some of these regions were found that they affect dopamine, some affect glutamate systems, others affect how the brain cells communicate, and others even go as far as affecting how the immune system responds. Remember earlier I was talking about the microglia, which if they become hyperactive are going to cause a problem at the end of the day. So there is a lot of ongoing research, but what I would like to insist on is that there is no single genetic loci or locus that has been found, and they have confirmed that if you are found with this kind of a change or at this locus, then you are going to develop schizophrenia. It is not there. So colleagues, we have always pledged that we shall be speaking for only 1 hour per day. I would like to thank you so much for listening to me, and allow me to summarize by saying that at the heart of it all, schizophrenia teaches us that the brain, just like life itself, depends on balance. And when that balance is lost, our role is to help to restore it with knowledge, with patience, and with care. I thank you so much for listening to me, and I hand the microphone back to Dr. Katamasadat. Thank you so much.
Wow, wow, wow. Thank you, Dr. Miyanga, for breaking down this rather complex topic for some people to us, who will help us understand very well the neurobiology of psychosis, of schizophrenia, and basically what happens at the synapse. I have really learned a lot, and I believe that I'm a lot wiser today for having listened, after having listened to you compared to how I was before, because indeed you have taught us. And I believe that for everyone who has attended today, they are a lot wiser to the understanding of the neurobiology of schizophrenia than those who have missed. After dissecting the neurobiology, tomorrow we shall be looking at the treatment. He has pointed on things like treatment-resistant schizophrenia. We shall go into details of this tomorrow. So the treatment basically depends on the understanding of today's session, this neurobiology. Because for whatever you're going to give a patient, whatever you tell a patient, it should come from the understanding of what Dr. Miyanga has talked about today. Today we shall have a poll. We shall have just 5 questions. They are MCQs. So the answers are there. You just have to pick out. These are coming from today's session and some from yesterday, hopefully. And just to mention this, some of you might find some of these in some of your exams that you might be sitting in the not so long future from now. So I request that we pay attention to this poll and we respond to it so that we get an understanding of this. It is also helping us to know whether indeed you people are actually understanding what we are giving you, the information that we are giving you, and indeed we are paying attention. And one thing I have noted is that many people join usually several minutes after 7:15, 7:20, 7:30. I want to echo this. We start at exactly 7 p.m. at 1900 hours, and we close at 8 p.m. So I request that we always join some 5 minutes before 7, because at exactly 7, the session actually starts, and you realize that many of us, when we join, we find that some slides have already moved, and yet you will have missed information. Now, like some of these MCQs, yes, the poll is up. Some of these questions, you'll find that they will, you might have missed some of the questions. In case the poll goes off your screen, if you're using a computer, please scroll to your right. You're going to find some icon with more. Then when you click on more, you're going to find the polls and stock quizzes, and you can click on it. Then it will give you the poll again so that you can fill. Please let us fill this poll briefly. Dr. Miyanga, there have been a few questions in the chat, and I request that we give you now the microphone to start answering the questions. The first question is from Edina. She's asking about what causes the initial changes in the glutamatergic pathway that you talked about, Dr. Miyanga.
Thank you so much, Dr. Edna, not only for the question, but even the information you've been sharing in the chat. So the initial changes in glutamatergic pathway in schizophrenia actually arise from NMDA receptor hypofunction, mainly on the GABAergic interneurons, as I earlier reiterated. These changes are driven by a mix of genetic mutations, abnormal neurodevelopment, and environmental insults, which may span from perinatal infections, oxidative stress, or even inflammation. So the result ultimately is disinhibition of excitatory neurons, causing excess glutamate release and the downstream dopamine imbalance, which is the hallmark of schizophrenia's neurochemical dysfunction. That's what I think. Thank
All right. Thank you, Dr. Miyanga, for that, for responding to that question. Dr. Eden also shared some article that people can look at when you want to understand some of these other associations. So Edina still asks, so does that mean that dietary changes may influence treatment outcomes in schizophrenia? I think this is coming after you talked about the gut brain axis and its involvement in schizophrenia. Yes, Dr. Miao.
Thank you so much. So I will reiterate one statement. We are what we eat. Yes, that certainly influences treatment outcomes in schizophrenia. Nutrients like glycerine, glycerin, magnesium, and omega-3 fatty acids actually have been found to support NMDA receptor and glutamate function. And diets that are rich in antioxidants and anti-inflammatory foods actually help to reduce oxidative stress. But the other side, or flip side, is that a poor diet again, for example, a diet which is high in sugar, saturated fats, and which is low in essential nutrients can actually worsen neuroinflammation. It can be associated with increased oxidative stress, and we know neurons are going to be dying. And it can be associated with a number of metabolic problems, which may impair glutamate and dopamine balance at the end of the day and reduce medication effectiveness and therefore worsen your presentation at the end of the day. So yes, 100% diet influences the cause of the illness a lot. We are what we eat. Thank you.
Right. Thank you, Dr. Mianga. I hope that Edina is getting these wonderful answers. Someone has said that the poll has exited. Please, if the poll exits on your screen, you scroll and look for where there is more. And when you click on more, you're going to see several options, captions, docs, notes. And under those options, you're going to find the poll. And then when you click on it, you're going to see the poll again so that you can respond to it. In case it is not there, I will ask Dr. Mwangs to share it again. So everyone is really saying thank you. Thank you, Dr. Miyanga. You have done a very work. Thank you for the beautiful presentation. Elaborate. Yes, elaborate and fantastic. Exciting presentation. Loud and clear. Yes, thank you, everyone. So another question is here from Diana. Is it possible for the slides to record? Yes, so these ones will be recorded. I will be shared. So for the slides, you can access them on the Neurotorium website. When you go to neurotorium.org, you can actually access all the slides that even have more information about this condition. But still, this recording will be uploaded to our YouTube channel that we shall be sharing as we go along in the next sessions. Dr. Edna says, Dr. Nagadia says, so these insults to the cholinergic pathway are happening over time and will culminate into the hypo or hyperfunctioning of the dopamine pathway, which will manifest as symptoms of schizophrenia. So I don't understand whether this is a question or a statement, but yes, this is actually very true. The link for the Neurotorium website has been shared. You can access it there. A question here, Dr. Does this mean there is a relationship between schizophrenia and NCDs like hypertension and DM, Dr. Miyanga?
Thank you so much, Dr. Kauba Abubek. I'm so happy to see you joining us here. Yes, Doctor, there is a clear and bidirectional relationship between schizophrenia and communicable diseases. Actually, yesterday I said that people with schizophrenia usually have a shorter lifespan. They may have a lifespan that is as shorter as 10 years. And it is because of preventable diseases. And most of them are related to non-communicable diseases such as hypertension, DM, and other cardiovascular diseases. So people with schizophrenia often develop non-communicable diseases because of several interacting mechanisms. You can think of the biological overlap. For example, chronic inflammation, oxidative stress, and neuroendocrine dysregulation, which especially involves cortisol and insulin signaling, are actually common both in schizophrenia and metabolic diseases. Let us talk about the antipsychotic side effects. A number of second-generation antipsychotics actually cause weight gain, insulin resistance, and dyslipidemia, which directly increases the risk of metabolic syndrome, diabetes, and hypertension. Talk of lifestyle factors. A poor diet, reduced physical activity, smoking, disrupted sleep patterns are frequent in schizophrenia, actually. But they have also been found to contribute to cardiovascular and metabolic risk. So I can say with a high degree of confidence that yes, there is a clear and bidirectional relationship. Thank you.
Yes, thank you, Dr. Miyanga. So for those who are not getting the poll, I think we shall be able to share the poll tomorrow again so that we see how people are picking up this information. And then tomorrow we shall give the responses or the answers to that poll. Like I said, some people might actually find some of these questions in some of their exams. So we shall give you SASI ahead of time. Another question is here that has come as Dr. Miyanga will respond to this as Dr. Mwesiga Manuel prepares to have a word or two about today's presentation. Dr. Miyanga, the question says, how long should an individual keep on antipsychotic treatment for schizophrenia? I think this one I can respond. This one we shall talk about it tomorrow when we are discussing the treatment principles for schizophrenia. And then we shall see how long should which individual be on what treatment. I think that one we shall get the answer tomorrow. Someone said that the impairment in functionality that may impede communication of another medical condition. Yes, this is now explaining the bidirectional relationship when we are talking about schizophrenia and then other NCDs. Dr. Mwesiga, you're welcome to say a word.
Okay, thank you, Dr. Katama, Dr. Muyanga. I was here thinking, I no longer have to give this presentation, considering I head the psychosis research working group in the department. So I think from now on, I'll be calling you to give it because I probably don't give a presentation as well as you've done. Thank you very much. We often neglect schizophrenia because it has a very small prevalence, but it's one of the most debilitating diseases on earth, probably more debilitating than most things that we see every day. I think the beauty of this conversation points a lot to early treatment and early intervention, which is something we're passionate about. So if you get things right early, during pregnancy, during fetal development, during early childhood development, avoid bullying, avoid cannabis. You really don't need to have onset of schizophrenia. And again, if you start good antipsychotic treatment early, consistently at the first episode, you should then have good outcomes. So I'm looking forward to tomorrow when we talk about treatment, and hopefully we can also talk more about early prevention, because many people think it's a done deal, a death sentence, and yet if it's treated well, people actually function well for a long time. So with those few words, I would like to thank Dr. Katama and Dr. Miyanga again. And Joy is asking, isn't the low prevalence because of misdiagnosis? No, generally it is a low prevalent illness. The reason why you see a lot of it at tertiary psychiatric care is because people come late for care. So generally it's not as prevalent, however, it is extremely debilitating. I think that's a very important point. And you see, I think to explain it well is you will have your first episode of schizophrenia probably at around the age of between 12 and 25, but you will have challenges, debilitation up to around 55, 60. So that is that's a long time to have an illness where you're losing neurons and losing functionality. So thank you again, and looking forward to seeing you tomorrow.
All right, thank you, Dr. Mesiga. So about the poll, we shall share this poll to the emails so that you can have a look at the questions which were there, and then you answer. Then tomorrow we shall give you the responses to these questions of today, and then tomorrow we shall have another poll. Tomorrow we shall be starting at exactly 7. So members, I urge us to log in a few minutes before 7 so that we don't miss a single slide, because whatever is being said here is really substance, and we really need this information in case we are to really care very well for our patients. David Kamya says that unfortunately, schizophrenia is the main face of mental health in our society, worsening the trajectory of stigma. Most people relate to patients seen on streets with schizophrenia, and yet it is not the most prevalent condition that we see. Actually, the most prevalent is things like depression, anxiety, which are very common. But when you say someone has gone to see a psychiatrist, for everyone indeed, as David said, people associate such a statement with these people with schizophrenia. Thank you everyone for attending today. I urge us to tune in tomorrow and inform others of the knowledge that we are sharing. This is week 3, and we have 3 more weeks to go on this Neurotorium Education series. So for those who are asking about the CPD points, since you registered and you entered your registration numbers within the registration, we shall then access you the CPD points. Thank you everyone for attending. See you tomorrow. Have a lovely night.